Welcome to this webinar on diverticular disease, diet and lifestyle advice. I'd like to welcome our speakers today, Dr. James Gotto, Consultant Gastroenterologist at Yeovil District Hospital, Dr. Emma Gregg, Consultant Gastroenterologist at the Practice Plus Group, Olivia Radcliffe, Community Gastroenterology Dietitian at Somerset Foundation Trust, and myself, Marianne Williams, Dietetic ACP in Gastroenterology from Somerset Foundation Trust. What this webinar will cover, we're going to look at which parts of the gut diverticular disease affects, the red flag symptoms that may suggest that you should actually be talking to your GP, what are the different names given to this condition and what do they mean? And this is a big area of confusion for people, so we'll go into this in a little bit of detail. What are the symptoms of diverticular disease and diverticulitis? What is the up-to-date dietary advice on fibre and lifestyle for diverticular disease and diverticulitis? Are your symptoms due to IBS or diverticular disease? Are probiotics useful for diverticular disease or diverticulitis? And finally, surgery in diverticular disease. What this webinar will not cover, it won't cover dietary changes for complicated diverticulitis, such as fistulas, abscesses, perforation, or bowel blockages. And we won't be looking at low residue diets for complicated diverticulitis. We also won't look at medication specifically for diverticular disease or other medical conditions such as hiatus hernia, inflammatory bowel disease, or bowel cancer. And finally, we won't be looking at weight changes or appetite changes associated with diverticular disease.
So which part of the gut is affected with diverticular disease? And for those of you who haven't considered the anatomy of the abdomen since school, this is a picture to show. So the red coloured area is the colon, also known as the large bowel or the large intestine. And the area in the middle of it, in white, is the small intestine or small bowel. So diverticular disease that we're covering in this webinar is most commonly occurs in the bottom left-hand side of the abdomen in an area called the sigmoid colon, which is shown here on the lower right picture, as you can see with the green arrow. And these are your red flags. So if you were to get any of these conditions, while they might be associated with diverticular disease, it's important to rule out other things. So you should always be concerned about blood in your stool, unintended weight loss. So that's weight loss where your weight is falling without you trying to lose weight, a sudden change in your bowel habit, your symptoms waking you up at night. And one of the things your GP may do when they see you is to do blood tests, which may pick up an unexplained anemia or a low iron level.
So Jim, do you want to take us through the different names for diverticular disease?
Yes, I agree. This is quite a confusing area, and we frequently hear the terminology used wrongly. A diverticulum is a little pocket or outpouch through the wall of the colon, typically at an area of weakness where a blood vessel which supplies the colon with its blood supply passes through the muscle wall. So a diverticulum is one of these pouches. Diverticular refers to more than one of them. There may be multiple. Diverticulosis refers to the presence of diverticula. And diverticulitis means infection or inflammation in one of these little pockets.
It's the itis that we're interested in. That means inflammation. Is that right, Jim?
Itis means infection or inflammation, and that would typically be associated with not just bowel symptoms and pain, but with fever and feeling generally unwell. No, so when we're investigating the bowel, maybe we're doing some bowel screening with a colonoscopy, we will very frequently see diverticulae presence in the bowel. In fact, the majority of people over 50 will have some diverticulae. And in the majority of those people, they're having no symptoms at all. And it's simply an observation. The symptoms attributed to diverticular disease are really the same as the symptoms attributed to irritable bowel syndrome. And this would typically be left-sided lower abdominal pain. Bear in mind that people from the Far East, their diverticulae may in fact be on the other side of their bowel. But for the majority of people in the Western world, they are in the sigmoid colon, which is on the left lower part of the abdomen. People may experience constipation or diarrhea, or perhaps alternating between the two, and perhaps wind and bloating.
But no inflammation or infection for straightforward diverticular disease, is that right?
No, as soon as there becomes infection or inflammation, it becomes diverticulitis.
So I think we've got a nice picture here, haven't we, of diverticular. Emma, do you want to take us through this slide?
So this shows you what the pockets can look like. As Jim has already explained, we often pick up these pockets when we're investigating people's bowels for other reasons. The presence of the pockets can affect up to 65% of people over the age of 65, so it can be well thought of as being wear and tear of the bowel. There's no doubt that it can run in families, so there may be a genetic component, and there is also an effect of diet and constipation, but most people don't have any symptoms from these at all. 10 to 15% of people will develop abdominal symptoms, which is diverticular disease, but they won't have any inflammation or infection if their bowel's investigated. But 5% of people can get more complicated disease, such as diverticulitis, where the pockets get infected or inflamed, or bleeding from one of these pockets.
So we're saying that actually of all the people that have these pockets, only 5% will actually get diverticulitis, where an infection with fever, etc. Is that right?
It's a very low number indeed, yes. But diverticulitis is used very commonly as a term in the population, without necessarily understanding the different types of diverticular disease that we've already been through.
So what about constipation, Emma? Do you take us through constipation, the different types of stools that we'd be looking at?
So the Bristol stool chart, you can see on the left-hand side of this slide, type 1 stool are the small, very hard ones, which are often difficult to pass and involve some straining. And the types then increase up to type 7, which is entirely liquid with no solid pieces at all. Constipation can be either where your stools look similar to types 1 and 2. You're going 3 or fewer times per week spontaneously without taking a laxative. A quarter of your stools are hard and lumpy, and quite often an experience that people have is that they go to the toilet, but then they still have the feeling that there's something there and they might or might not need to go again.
So how does constipation cause diverticular? Well, I think there's a bit of controversy about how much constipation is involved with causing diverticular, but looking at the Johns Hopkins Medicine website for their patient information, one of their explanations can be that when you've got constipation, you may be straining to move your hard stools through, and that extra straining pressure might pressurize any weak spots in the colon and cause them to bulge out, and those bulging out cause the pouches, which are the diverticular. What's your feeling about this, Emma and Jim, about constipation being linked directly to diverticular?
I think that this originally arose from some epidemiological evidence that there's more diverticulosis in the Western world than there is in the Eastern part of the world, and the theory being that we have a worse diet with lower fibre. It's a very attractive hypothesis, and one can imagine this increased strain causing these pockets. But of course, as Emma's already mentioned, we also know that there is a genetic tendency, so it's certainly not the only factor.
So what about diet and lifestyle, Liv? A lot's changed in the advice, hasn't it? And this advice has been going on for many years, and I'm still getting patients coming in with advice, but it's changed a lot recently. Do you want to take us through that?
Yes, so previously it was advised that you adopt your intake of fibre depending on whether or not you had symptoms with diverticular disease or whether you had diverticulitis. We're now very much moving away from that, and we know that the diet that you should be following for diverticular disease is very much in line with general healthy eating advice. So follow a healthy, balanced diet which contains whole grains, fruits, and vegetables. There is no need to avoid nuts, seeds, popcorn, or fruit skins, and that is where there's been the change. So previously, you would have been advised by a healthcare professional to avoid those foods. We want you to increase your intake of fibre gradually. As Jim has already said, we know that diverticular disease is less common in those countries where they follow a more plant-based diet or a naturally higher fibre diet. So the recommended intake of fibre is 30 grams a day.
It might be really useful to give some examples of what you could include in your diet that would actually end up giving you about 30 grams a day of fibre. We've got a slide here showing that if you had a breakfast with a medium-sized bowl of porridge with, say, banana and apple on, that would give you about 8 grams. And if you had lunch with 2 slices of wholemeal bread and a small tin, 200-gram tin of baked beans, that would give you another 14 grams. And then an evening meal, if you had something as simple as a jacket potato with some vegetable curry, so for instance, including lentils, green beans and carrots, that would give you another 12 grams of fibre. So altogether, you would be getting 30 grams in a day.
And for more guidance on how to achieve that practically with food, you can refer to the British Dietetics Association or the BDA fibre fact sheet in the further information and handouts at the end of the webinar.
So having looked at the changes in advice for fibre intake, we will now return to looking at the other up-to-date advice for diet and lifestyle in diverticular disease. And I'd like to hand back to you, Liv, for this.
Having an adequate intake of fluid, so that again, guidelines is around 2 litres or 8 cups a day. Quitting smoking. For those that are overweight or obese, so that's anyone with a body mass index or BMI of greater than 25. And if you wanted to calculate your own body mass index, you can use the NHS BMI calculator. So if you're someone that sits in that category, we know that losing weight may confer a benefit with regards to the management of diverticular disease. Increasing your physical activity, if it's safe and advisable for you to do so, again, is important in ensuring a regular bowel function. And finally, if you found that you have increased your intake of fibre, fluid, and your physical activity, and you're not seeing an improvement in bowel function, you may wish to try laxatives. So it's worth having a discussion with your GP, pharmacist, or someone at your local chemist regarding the use of these.
So, Liv, with regard to the dietary fibre intake, I think it's quite interesting to look at some of the new research that's come out supporting the fact that there should be a big change in the old guidance. So, actually, looking at individuals who eat plenty of fibre, they're much less likely to develop diverticular disease in the first place, which goes along with what you were saying just now. Is that correct?
Yes, so we know that when you look at the prevalence of diverticular disease, it's much more common in those countries that have a more processed or naturally lower fibre diet in comparison to where it's lowest. So in those countries that have a more plant-based or higher fibre diet. So we know that having a high fibre diet is actually protective.
Okay, and actually the increase in fruit and cereal fibre can actually reduce the risk of being hospitalised. So once you've got diverticular disease, you're less likely to get diverticulitis, the itis being the infection, if you're having more fruits and cereal in your diet. So that's new evidence that's come out showing, you might actually reduce your risk of being hospitalised by having more fibre. And so the normal unrestricted diet is totally safe and advised for all those with acute uncomplicated diverticulitis. You no longer need to avoid nuts, seeds, popcorn or fruit skins. And I think that's really important to underline that advice is now out of date, and actually you're better off having more fruit and fibre and vegetables, etc., in your diet. And if we look at the different types of fibre, it's particularly the insoluble fibre that's useful. Is that correct, Liv?
Yes, so those insoluble fibres, so those foods which are left intact, they cannot be broken down. So they pass through the bowel undigested, adding to the bulk of the stool. And that just helps to speed up the movement of food through the gut. So it's important for the management of diverticular disease.
So if you're moving that food faster through your gut, you're going to be less likely to get the constipation as well. If we look at insoluble fibre, you've got the vegetables, including skins, legumes, potato skins, fruit skins, nuts and seeds, the grains, the oats, the brown rice, whole wheat, cereal brands, things like breads that are whole wheat, 50-50, granary bread, for instance. But I think it's really important to understand that many of these foods have both insoluble and soluble fibre in. And the soluble fibre is very important as well, but the insoluble fibre is what keeps those bowels moving smoothly and more rapidly through the gut so that you don't get constipation, and that will hopefully help reduce the chance of developing diverticular.
So we're aiming for about 30 grams of fibre a day, or 5 portions of fruits and vegetables. And it's worth saying that there are health benefits to going beyond those guidelines. So there's no reason why you can't increase your intake of fruits and vegetables or fibre beyond those guidelines. But we just say keep it in line with your tolerance. So if you find that by increasing your intakes of those foods way beyond those does worsen symptoms, it's just about bearing that in mind and perhaps bringing it down.
I get a lot of patients who have been told they've got diverticular disease. They hear the word disease on the end and they think, oh my Lord, this must be what's causing all these symptoms. When in fact, that's a bit of a red herring. And generally speaking, these symptoms they're coming in with are due to a different condition completely, which is irritable bowel syndrome. Is that correct?
That is completely correct. And diverticular disease or diverticulosis is often an innocent bystander in all of this. All of these symptoms can benefit from some dietary change, as we've already talked about, and also some basic medication. So, for example, crampy abdominal pain may benefit from things like peppermint oil capsules, which you can buy pretty easily in the health food shop or in the chemist. So it's worth treating as irritable bowel syndrome.
Emma, it's also very important to point out that there are very useful changes you can make to your diet if you suffer with these IBS symptoms. And I direct people to our IBS section on this website, where you'll find some first-line advice and advice on more complex diets for IBS, such as the low FODMAP diet. However, it is always preferable to see a dietitian, if possible, to take you through these dietary changes.
The time when you should be concerned that you might have something like diverticulitis is if you're starting to get a temperature or you become unwell, which is very different to these sorts of symptoms.
It really is a minority of people who ever get that. When you consider that the majority of the population over 50 has diverticulae.
That's very, very helpful. Thank you for that, because I think it's a big area of confusion for patients.
I would add that diverticular disease sounds somewhat alarming, and the very nature of alarm is that it causes distress, which can aggravate irritable bowel syndrome.
So just to underline what we're saying here, the gut symptoms, such as wind, bloating, abdominal pain, etc., are often actually caused by IBS and not diverticular disease. But that the diagnosis of diverticular disease itself can ironically end up causing these IBS symptoms to flare up.
Yes, I think the terminology can cause anxiety and aggravate symptoms.
I think it's important, though, just to highlight, do check with your GP if you've got any of those red flags as well. If you've got blood in your stools or unintended weight loss or a sudden change in bowel habits, so you've always been slightly on the constipated side and suddenly you get diarrhea more regularly, that would be something that we would call a red flag, and you'd need to discuss with your GP. And if your symptoms start waking up at night, and as Emma mentioned earlier, if your GP's done blood tests and you've got unexplained anemia or low iron levels, all of those things need to be discussed with your GP. So it's very important to rule out other conditions. Talking about diverticulitis, would you mind taking us through that and explaining what that is?
Well, diverticulitis is when one of these pockets or pouches, a diverticulum, gets some inflammation or infection in it. Of course, that diverticulum will be there for many, many years, and there may be numerous of them. So why it happens at a particular time and why it happens in a particular person is not particularly clear. But when it happens, some of the hallmarks would be, in addition to the symptoms we've been discussing, one has fever and may be feeling generally unwell rather than just the discomfort and pain and bowel problems. One will be, let's say, systemically unwell. And when the GP or another doctor does tests, they will find signs of infection or inflammation in the blood tests.
So you might get a sudden change in bowel habit when you've got an attack of diverticulitis, is that right? So you might suddenly get more diarrhea, for instance?
Oh yes, the diverticulitis is not something which will tend to grumble on. It's something which will happen out of the blue, and in much the same way as with appendicitis, one will suddenly become unwell. These symptoms will often resolve and settle down spontaneously. We know that if patients are sick enough to be admitted to hospital, antibiotics do not make patients get better any more quickly or reduce the number of complicated episodes of diverticulitis, such as abscesses and severe complications.
Can you have just a one-off attack of diverticulitis and never suffer from it again? Is that possible? Or once you've had one attack, will you always get repeated attacks?
No, in fact, the majority of people who have an attack of diverticulitis will never have an attack again.
How long does a flare-up usually last?
A flare-up of diverticulitis, when there's infection and inflammation, depending on its severity, may last for a few days, although there are certain situations where it's more complicated. But in those situations, the patient will almost certainly be in hospital. It will be very obvious that there are more significant problems.
When the diverticulitis has resolved, would you expect the patient to have any symptoms at all?
A large number of people who've had diverticulitis will go on to have further symptoms. I think it's about a quarter of patients will continue to have symptoms. However, the vast majority of those are not due to further diverticulitis, and the cause may not be readily identifiable. But in the majority of those, it will in fact be due to irritable bowel syndrome.
So you're saying that if somebody's had an episode of diverticulitis, they may actually have triggered their irritable bowel syndrome?
Exactly. Of course, if someone then has ongoing symptoms and persistent symptoms, they may initially need some investigations to be sure that there isn't another process going on, an alternative diagnosis. If that investigation has been done and there is confidence, then one can revert to managing it as irritable bowel syndrome or as diverticular disease.
And the other thing to say is that we usually leave it 6 to 8 weeks after an episode of acute diverticulitis before going ahead and undertaking an endoscopy. Because there's no doubt when you have diverticulitis, you have infection or inflammation of one of the pockets, which makes it a little bit weaker and does increase the risk of perforation. So a CT scan is done if a patient is unwell with acute diverticulitis, which rules out anything acute, and then often is followed on with an outpatient endoscopy at a time when it's felt to be safe to do so.
Most people with uncomplicated diverticulitis don't need a colonoscopy. The guidelines generally suggest that if it's complicated diverticulitis, they should have one. There may be a slight increased risk of cancer in those patients. So as you say, at least 6 or 8 weeks after the episode. But most people don't need a colonoscopy. And if a colonoscopy is performed, it isn't to diagnose the presence of diverticulae, which the majority of us have got. It is more to exclude other things.
So this slide is just to emphasize that for uncomplicated diverticulitis, we do not need to be making any specific changes to the diet or lifestyle. So it's very much keeping in line with general healthy eating guidance. So following a healthy, balanced diet, which includes whole grains, fruits, and vegetables. And just emphasizing that there is no need to avoid nuts, seeds, popcorn, or fruit skins. And that's a real change. Again, that's something that we had been previously advising. So we want to be increasing our intake of fibre, aiming for about 30 grams a day, and do that gradually. Again, aiming for an adequate intake of fluids, so that 2 litres or 8 cups a day, considering stopping smoking. And then for those that identify themselves as being overweight or obese, so that's anybody with a body mass index of greater than 25, considering weight loss to support in the management of the diverticular disease and diverticulitis. For those that are physically able and that it's safe to do so, increasing physical activity. And finally, considering laxative use. So for those that have increased their intake of fibre and fluid and physical activity without a noticeable improvement in bowel habit, it's worth just having a conversation with your GP, pharmacist, or local chemist to see whether laxatives may be advisable.
an area that a lot of people get confused with antibiotics, because they assume that if they've got diverticulitis, so they've got the infection, that antibiotics should be used. And are we saying that that's not necessarily the case?
Well, trials have told us that there isn't any benefit in having antibiotics for uncomplicated diverticulitis, and you're more likely to get problems as a result of taking those antibiotics, because we know antibiotics can affect your own gut bacteria and can increase the prevalence of bad gut bacteria, and thus you can get infections like Clostridium difficile, while there isn't any actual benefit to making your disease course shorter. So you still have symptoms for as long, and it wouldn't be of any benefit.
Okay, so it's not a surprise if you're discharged from hospital not having had any antibiotics prescribed.
And the other thing we know is that patients should avoid taking non-steroidals. So that will be drugs like ibuprofen or Voltarol or naproxen, or opiates such as morphine or codeine, because these can increase the risk of more serious complications like perforation or the gut failing to move things through, so becoming more constipated, and again increasing the risks of complications as a result.
And this is for uncomplicated diverticulitis, isn't it?
It is, to avoid it becoming complicated diverticulitis. So what probiotics are is they're a form of bacteria which you can take in your diet, and the aim is to try and change the gut bacteria that you already have in favour of a more healthy form, which are less likely to cause you symptoms. So they're taken in the form of foods and as supplements, as capsules. And while they don't change the gut bacteria long term, they will potentially change it short term, or for as long as you go on taking these products. There isn't a lot of evidence that they will make any difference for diverticular disease or diverticulitis at all, which is why they're not recommended by NICE. And the other thing about them is that they're non-prescribable for this indication. So it's quite hard to justify that, because those are quite big costs for something with no proven benefit to any form of diverticular disease. Okay. So any of the subtypes, there's no evidence for any of them being of any benefit with probiotics.
If you keep having repeated flare-ups, at what point do you need to have surgery done?
There is no clear and definite answer to that one. The decision as to surgery will be made on a very much an individual basis. It depends on the general level of fitness of the patient, because obviously having surgery and part of one's bowel removed is a significant procedure with risks. If there are complications such as strictures or narrowings of the bowel, or there are fistulae where one piece of bowel has been connected to another part of the bowel or another organ, then that surgery may well be necessary. If the surgery is simply for recurrent episodes of diverticular disease or diverticulitis, it may reduce the subsequent episodes, but not in everyone. Even people who have had surgery, 15% or so can still go on and have further attacks of diverticulitis, because diverticuli can occur in another segment of the bowel which hasn't been removed.
So even if you had surgery to remove that one particular area, you could go on and have more attacks at a later date. So it doesn't protect you against further attacks by having surgery.
No, and 25% of people who have had the surgery, even if they don't have ongoing episodes of diverticulitis, will continue to have abdominal pain, probably related to irritable bowel syndrome. So it could be very disappointing to have the surgery attributing one's pains to diverticular disease, only to find that in a quarter of those patients, it doesn't resolve their symptoms. Smoking and obesity, as well as all the dietary factors, it makes a lot of sense to address those first before embarking on surgery.
In terms of managing complicated diverticulitis, this is where the situation has gone beyond inflammation or infection of one or more pockets. So that you may have developed a fistula, which is an abnormal connection between the bowel and either another fold of bowel or another organ altogether, such as the bladder or the vagina. An abscess, which can grow out of one of these pockets. Perforation, which is where the pockets tear and you end up with a hole in the wall of the bowel, or a blockage of the bowel where the diverticular disease is so significant that things can't pass through, and that will lead to the inability to eat properly. So we're not covering any of these conditions. You're likely to be an inpatient if you have any of these things, because they will often make you quite unwell. And it will be a case of managing your individual condition. So we can't give any specific advice.
In the diverticular section of the patient webinars website, you'll see a further information and handout section. Please look here to see the links and handouts to accompany this webinar. Thank you for listening. We hope you found this webinar helpful.